So today we'll be mainly discussing the procedures for the knee joint, mainly the ultrasound guided procedures for the knee joint. Instead of going for the basic ultrasound, let us see a little more advanced and the important parts. The first part of the ultrasound is definitely knowing the anatomy. And as we all know, our knee is just like this. It is having two main bones, one at the top, that's the femur, and below we have the tibia and fibula. Remember, fibula do not comes in formation of the knee joint, so main bones are two. Above it's the femur, below it's the tibia. Anteriorly, we have the patella. So basically, there are formation of a patellofemoral joint, there are formation of the medial and lateral joints of the knee, which is actually the femorotibial joints, and that forms the basic bone framework of the knee. Now, before going further, let us see what the because it's the ultrasound, so we have to understand the apart from the bone other structures. If it is a fluoroscopy, you can think of only about the bone, but here you have to more stress on other portions as well. So bony part already described. So let's go back to the what are the framework other than the bone we have. First, the deepest one. So apart from the bone, then it is covered by the these structures. So what are those structures around? So they are the mainly ligament and bursa around the knee. So knee is strengthened by the multiple ligaments, bursa, cartilages. Okay. So if you look at from the anterior side, we have from the top, this is the coming, the tendon, which is the quadriceps tendon, which is actually four muscles joining together. Above, it is the rectus femoris, vastus medialis, lateralis, and intermedius, and they forms this quadriceps tendon, which joins to the upper polar patella. From there, some fibers goes attaches to the patella, and some fiber continues below, and as a patellar tendon, it goes attaches to the tibial tuberosity. So this is one of the important tendon to know. Sometimes this patella itself is considered as a sesamoid bone in the tendon of the quadriceps, but in that way, ideally this should be a tendon and this should be a ligament. But if you look at, we do not separate this way. They are basically fibrous connective tissue fibers. They are joining these structures. And this structure is very important because it is related to multiple bursas. So what is bursas? These structures are related. Just anterior, we have the subcutaneous prepatellar bursa, or you can simply call it a prepatellar bursa, which remains just under the skin and subcutaneous tissue. And when fluid is filled to this bursa, there is a specific name of the disease. Can anyone tell? Those who are doing ultrasound? When this bursa is having fluid? No one? Sub this prepatellar bursa? This is prepatellar bursitis. So what is the other name of the prepatellar bursitis?
Housemates.
Housemaid's knee. Perfect. Then come down and then we have another bursa. This is the subcutaneous infrapatellar bursa, sometimes also known as the superficial infrapatellar bursa. Again, there is a name when the fluid is collected within it, but it is called
Clergyman's knee.
clergyman's knee. So you know everything. I'm just recapitulating. And similar to it, just deep to it, there is another bursa. This is the deep infrapatellar bursa, and there could be accumulation of fluid. But there is a difference between the superficial and deep that we know. In deep infrapatellar bursa, a small amount of fluid can be present normally, but which is not usually present in a normal case of the superficial infrapatellar bursa or prepatellar bursa. So if you get a very small amount of fluid in the deep infrapatellar bursa, that could be absolutely normal. Now, if you go to the lateral side, then we have the other important structure. So this is the junction between the tibia and the fibula, and there attaches another ligament which is known as the lateral collateral ligament. Remember, lateral collateral ligament is not between the tibia and fibula, rather it is between the fibula and the femur. Okay, and it is not between the tibia and femur. In between tibia femur in the lateral side, there is another ligament which is known as the anterolateral ligament. So that's the difference. And at the femoral head, there is also another ligament, that is arcuate popliteal ligament, along with attaches the biceps and also a connective tissue structure that is also very important, which is known as the can anyone tell which connective tissue transfer attaches here? It is the iliotibial band, which is actually a condensation of the deep fascia of the leg. Okay. So I think these are the important ligamentous structure at this side. If you go at the medial side, here we have the medial collateral ligament. Medial collateral ligament is having its two layers. One is the deep layer, one is the superficial layer. Deep layer attaches with the tibia and fibula, tibia and femur, and also it attaches with the meniscus. So deep fibers are differentiated into the menisco-femoral fibers and the meniscotibial fibers, and superficial fibers run through and through, and it from the joint line it goes approximately 7 centimeter below, and in between these two layers there is an important vessel, that is the medial inferior genicular vessel. So where to search for the medial inferior genicular vessel? Is under the medial collateral ligament in between the superficial and deep layer of the bursa. And three muscles are there which are attaching from different sides but attaching to the same point. So that is surprising in the knee. There are three muscles coming from the three distinct compartments. So what are those? One is from the anterior compartment. It is the sartorius. One from the medial compartment. It is the gracilis. And one from the posterior compartment. It is the semitendinosus. They joins together to join at the same point at this point of the tibia, which is actually known as the pes anserine tendons. Okay, and there is a bursa in between these tendons and the bone. This is known as the pes anserine bursa. And in early osteoarthritis knee, sometimes you will observe that this bursa is actually fluid filled, and within this bursa there is accumulation of fluid. Okay, and that causes pain. Now the question is, those days when we do not have ultrasound, it has been found in a number of cases of the patients around bursitis, there is actually no fluid. Because when we do not have any idea, it is only on the clinical judgment, we used to diagnose this bursitis much more commonly. But with the modern techniques, now when we do the ultrasound, in a number of cases, we see there are no fluids in the bursa. Rather, there is a tendonitis of the patient's line. So remember always this point. Nowadays, what we have found, and studies also found, that in a number of cases which were suspected as a deep patient's line bursitis in past, they are actually a tendonitis of the patient's line tendons that could be possible in certain situations. Okay, so let's go about the posterior part. So in the posterior part, again, we have the joint capsule, which is covering all parts. Now let's go to the muscular part. So this is more important, especially because in the ultrasound, we'll be able to see the muscles. So we need to know the muscles properly. So as I told, in the front side, we have the quadriceps femoris and rectus femoris, which starts from the anterior and inferior iliac spine and continues below and joins with the other quadriceps muscle. They are the vastus lateralis, vastus medialis, and if you hide it below, you will get the vastus intermedius, and they join together to form the quadriceps tendon. If you hide all of them, then there is a very small muscle which is known as the articularis genu, that is taking origin from some portion takes origin from the femur itself. Some part of the fibers takes origin from the intermediate vastus intermedius actually, and they continues and attached to the upper pole of the suprapatellar pouch. So that suprapatellar pouch is a synovial bursal extension in between the quadriceps and the femur, and this extension is pulled by this articularis genu when the patient is extending, or the non-human is extending their legs, and that is the importance of it. Now coming to the other posterior muscles. So in the posterior side, if you go at the medial side, then we have two important muscles, semimembranosus and semitendinosus. And in the other side, we have the biceps femoris that is attaching to the head of the fibula. And below, we have the gastrocnemius. In the posterior part, I will not be going into much detail of the posterior part. But here, one thing I should always mention that in between the medial head of the gastrocnemius and the semimembranosus, so in between these two, there is also one bursa, which is known as the semimembranosus, medial head of the semimembranosus and gastrocnemius bursa. And when it is fluid filled, it is commonly found in association with the osteoarthritis. Sometimes there is a flap-like mechanism that develops between the knee fluid and this bursa, and this is known as the Becker's cyst. Sometimes it can be palpated as a lump in the posterior part of the knee, and early Becker's cyst and the painful Becker's cyst needs aspiration and corticosteroid injection, and it's a very good procedure. Sometimes there could be recurrence. In that case, surgery could be considered. And as I told, this is one of the important structure, that is the iliotibial band. And remember, iliotibial band can produce two types of symptoms. Well, we are more concerned about the symptoms, not the anatomy. That's why I got into the symptoms first. One, in case of runner, it might rub over the lateral condyle of the femur. So in that case, there could be inflammation at this point, which is known as the iliotibial band syndrome. And sometimes it can happen when it is going just over the greater trochanter. It is just scratching against it, and that is known as the external snapping hip syndrome. Okay, or sometimes it could be associated with the trochanteric bursitis as well. So trochanteric bursa remains slightly below at this point, okay, just over the greater trochanter. So there could be accumulation of fluid at this point and at this point. In both the cases, it can cause pathology and pain. So I think with this, anatomy part is clear to you. Okay, someone has written house veterinary. Very good. Okay, but you can switch on and answer because it's a very small group class what we take in the IAPM, and your questions are always welcome. So let's start again back to the presentation, and let us see what are the important points. Because see, our aim is not to be a sonologist, or our aim is not to be a person with a great knowledge of anatomy, but our aim is to treat patients. Very simple. So what are the causes of the anterior knee pain, and what when the patient comes, you have ruled out the red flags. That is the first part of it. So fracture, tumor, and everything you have ruled out with the investigations if required. And then you are thinking what could be the chronic cause for the musculoskeletal pain for this patient. Now, what could be the common causes for the anterior knee pain? First of all, it could be a quadriceps tendinopathy. Can happen in case of runners, in the patients, young patients, footballers, they are more prone to develop. Then there could be patellar subluxation or dislocation. There could be a condition already I have discussed, that is the housemaid's knee, which is known as the prepatellar bursitis. Then there could be a tendonitis of the patella, and which is known as the jumper's knee. Now, one thing I like to mention here. So those who are doing my first classes initially, this is my first class. So remember, one thing I always say, regarding tendinitis, in early phases, you might not be able to see anything. Okay, always remember, it is not always that every time you will be getting something in the tendinitis. It could be a simple pain there in the tendon, that could be the first sign of the tendinitis. But when it progresses, it mainly causes four signs. First, there will be loss of fibrillar structure, number one. Number two, there will be reduction in echogenicity. So the area will become hypoechoic. Number three, what will happen? The tendon will become swollen. And number four, in Doppler, in acute and subacute cases, you might see slight increase in Doppler signals. Okay, so these are the four signs that you can expect in case of an ultrasonography of a tendinopathy. And this you remember for all of your ultrasound time, because till date it is the only thing. Sonography is coming, but still sonography is not very well available, and I will not discuss that detail in today here. So coming, the thing is the what we have the patellar tendinitis. So symptoms will be the same as I told. These four symptoms will be present. Then comes the superficial infrapatellar bursitis. In superficial infrapatellar bursitis, there is always inflammation and fluid in the superficial infrapatellar bursa. Then comes the deep infrapatellar bursitis. Then tibial apophysitis or the osteoid lesion, patellofemoral pain syndrome or chondromalacia patelli, which is actually the degeneration of the cartilage at the posterior part of the patella. And it is also known as the runner's knee. So from this slide, you just remember what is housemaid's knee, what is jumper's knee, what is clergyman's knee, what is runner's knee. Okay, so many things you have to remember here. Now coming to the medial knee pain. So what could be the possible problems? First of all, medial collateral ligament sprain, medial meniscal tear, pes anserine bursitis, median plica syndrome. Both are all are mostly self-explanatory. Only the last one, median plica, what it is? It is an embryonic fold that remains sometimes in certain adults in the medial part of the knee, just below the patellar retinaculum, and this structure sometimes can cause pain in the medial side of the knee, which is known as the medial plica syndrome. Now coming to the common causes for the posterior knee pain. First of all, as I told about the Baker's cyst, so there could be an painful Baker's cyst either because of the tension fluid within it or sometimes because of infection. It can be a painful Baker's cyst. Most commonly in chronic degenerative cases, we get tensed painful Baker's cyst. Next comes the semimembranosus bursitis. Obviously, semimembranosus bursa is also there. It could be affected. Hamstring tendinopathy, popliteus tendinopathy. Popliteus is a small muscle going to the lateral side and attaching to the lateral part of the femur. Mainly, it stabilizes the knee. So, it can be also involved. Then comes the posterior horn of the medial or lateral meniscus tear. Remember, meniscus tear is one condition that cannot be completely evaluated with the help of the ultrasound. Here you have to take the help of the MRI. Next comes the posterior cruciate ligament injury, and this is also one structure which is quite deep and not properly visualized. It's possible to see portion of it, you will be able to see, but for surety to diagnosis a PCL injury with the help of ultrasound is difficult because the vision is not that clear. It is much deeper structure. Gastrocnemius tendinopathy or strain can be diagnosed. Osteoarthritis can cause a global knee pain, anterior, medial, lateral, posterior. So that could be one cause of the posterior knee pain as well. Deep vein thrombosis, popliteal artery aneurysm, and loose body. So that could be cause of the posterior knee pain. But while we're going for the lateral side, there could be iliotibial band syndrome, lateral meniscus tear, lateral collateral ligament injury, popliteus tendinopathy, biceps femoris tendinopathy, proximal tibial joint dysfunction, lateral compartment osteoarthritis, patellofemoral pain syndrome, osteochondral lesion, synovial plica syndrome, common peroneal nerve entrapment in the lateral side, lateral retinacular irritation syndrome, stress fracture of the lateral tibial plateau, guidus tubercle bursitis. So they are cause for the lateral lateral knee pain. Now let us go a little about the steps of the ultrasound evaluation, because ultimately we need to perform an ultrasound evaluation. So let's see what are the ultrasound evaluation and how to perform the common ultrasound evaluation. So first come to the anterior knee. So in the anterior knee, when we look at in three planes. One in the suprapatellar plane, both in the longitudinal and the short axis view, also in the infrapatellar plane in the longitudinal and the short axis view. So in the suprapatellar longitudinal scan, what we see is this. So what is there? So we can see here at this portion, we have the bony structure. This is the patella denoted by the P. Then here we have another bone, that is the femur. So we have the femur here at this point, okay? And in between, we are having one structure running above it. Okay, just under the skin and subcutaneous tissue, and this is the quadriceps tendon. So if there is quadriceps tendinopathy, this structure will be increased in height. In case of quadriceps tendonitis only, increased in height, loss of fibular structure, and all 4 points I have already mentioned to you. And in some cases, there could be a tear that can appear intra-substance tear as a black line, or sometimes there could be discontinuation in a complete tear of the quadriceps tendon. So these are the common pathologies, and sometimes there could be calcification. Okay, so that can look like, based on the density of the calcification, that can show you different appearances. Okay, now what are the other important points you are seeing? Here you can see there is a fat pad. So what is this fat pad? This is femur, and this is above the femur or anterior to the femur. If you see patient is standing, so it is anterior to the femur. So it's the prefemoral fat pad, and here lies another fat pad which is known as the suprapatellar fat pad. And in between the prefemoral and the suprapatellar fat pad, you can see a black line. So this black line is nothing but the extension of the synovium, or it is known as the suprapatellar pouch. So what can happen in the suprapatellar pouch? There could be inflammation at this point. There could be fluid here. Okay, and that needs aspiration. And if you want to inject anything, like if you want to do a PRP injection, or if you want to perform a viscosupplementation, in all the cases you can take the help of this suprapatellar fat pad. In fact, nowadays we have almost forgotten the lateral approach. In most of the cases, we try to figure out this point in a short axis view, and then we put our needle here. Obviously, when there is fluid accumulated, it is much easier to see, and when there is no fluid, it is a little bit difficult, but not that difficult as well. Now, this is the quadriceps tendon that we can clearly see at the top. And in the transverse scan, what we can see, in the transverse scan, we can see here it is the rectus femoris, vastus medialis, vastus lateralis, and the vastus intermedius. And sometimes this is called the figure of 8 appearance because of presence of this. So here you can see this figure of 8 appearance that is formed by the mainly rectus femoris and the vastus intermedius, and below we can see the bony structure of the femur. And if you come down from this area, you have just come a little down. In that case, you can see the femoral trochlea and the trochlear cartilage above the femur, as well as we will be able to see the quadriceps tendon, and slightly above it, we will be able to see the patellar pouch as well. Okay, so these are very, very important, and you have to know the suprapatellar and parapatellar joint recess as well. When we look from the slightly from the lateral side of the patella, we will get the suprapatellar recess like this. And also there is a way to evaluate the retropatellar cartilage. It is actually visualized in the medial side, and it is can be seen when examined properly. Now coming to the patellofemoral ligaments, that can also be observed. If you put the probe like this, then we'll be able to see the patellofemoral ligaments. And then we are having the infrapatellar longitudinal scans, in which what we see, this is also a very important view. At the top, this side you can see this is the patella. This side it is the tibia. In between, this is the patellar tendon, and here lies a fat pad which is known as the Hoffa's fat pad. Okay, and at this point usually lies the deep infrapatellar bursa. Above it, if you get fluid, it will be the superficial infrapatellar bursa. At this point, if you get fluid, it will be the prepatellar bursa. So I think the most important structures here, if you are understood, and whenever there is tendinosis at this point, it could be known as the patellar tendinopathy, and also it is known as the jumper's knee. Okay, so we understood two very, very important scans. Then we will be also see the transverse scan at this point to confirm the findings that we have found in the longitudinal scan. In both the cases, always remember, go to the medial and lateral side one by one to check the structures. That is very, very important. So these are all about structures, and some pathologies are also there. There could be a quad tear. Here you can see a little bit quadriceps tendon tear that I have mentioned a little ago. And there could be a complete tendon tear as well. So at this point, there could be a complete patellar tendon tear that can be seen at this point. Okay, so it is the patella. Here it is supposed to attach to the tibia, but in between there is a break and the fibers are retracted at this point that you can see. And there could be quadriceps and patellar tendinopathy, which features I have already shown. This is the picture. So in comparison to the normal, you can see the hypoechogenicity, the broadening of the tendon, and all the features as I told. In patellar tendinopathy, this is the picture showing the increased uptake. That means increased Doppler signals at the patellar tendon at the affected area. In the calcification, you can see a fluffy appearance in the patellar tendon. Okay, so this is the patellar calcification. These are gouty involvement of the patellar tendon, which are showing a little more dense calcifications at this point. Okay, and last but not the least, we'll be discussing, not last actually, we'll be going to a little bit deep also, a few other structures as well. So we have to know about the osteoarthritis knee. One thing is very important. I do not started with the osteoarthritis knee because though it is a very big part in the knee pain management, but what you know, most of the people, if you get a knee patient, they do not go deep dive into find out the causes of the knee pain. Rather, they finally get a little bit of osteoarthritis and they tag it as the osteoarthritis knee. So with time, you will understand that it is not all cases the pain are because of the osteoarthritis knee. Definitely some pain can be attributed by it, but not all patients. Because in some patients, yes, after treatment, successful treatment of the conservative management of the osteoarthritis also, we have found the pain is persisting because of the other structure. So osteoarthritis is mainly the degeneration of the cartilage, mainly the meniscal cartilage as well as the femoral cartilage, and which is associated with the pain, tenderness, stiffness, and the loss of function and disability, deformity, effusion, and swelling of the knee. And so, what are the structural findings? Remember, in osteoarthritis, in ultrasound, there are two types of findings. One are the structural findings, in which you can say there is loss of cartilage sharpness. So this margin you can see as a sharp margin of the femoral cartilage. Here that sharp margin is lost. Number two, thickening. Here see, uniform thickening of the cartilage is maintained. So it's a homogeneous cartilage, uniformly black cartilage. But here it is not uniformly black. The cartilage thickening varies, and also it from the homogeneous structure it becomes heterogeneous structure. In relation to this, I would also like to mention another very important point, that what happens whenever you see a black structure. Remember, there could be three possibilities. One, it could be a cartilage. So check the compressibility. Cartilage will be non-compressible. It could be a synovial hypertrophy. But synovial hypertrophy are not usually Z black. Rather, there are some bony strands, some small whitish strands might be present in case of synovial hypertrophy. And synovial hypertrophy is also non-compressible, but margins are not clear, unlike the cartilage. And another possibility could be a fluid, that could be an effusion, but effusion always check with the compressibility. Unless and until it is very tense, it could be compressible in most of the cases. It will change its structure or nature. So that we'll be able to understand it is because of this. So this is the changes in the femoral cartilage that we can see. The trochlear cartilage here is regular. This is a patient with the OA. So these are the changes that we see under the ultrasound. Now, other signs that we might see are the bony erosions and osteophytes in case of osteoarthritis. So here you can see what happened. This is a normal. This is the femur and the tibia. This is the in between this portion. In between this portion is basically the cartilage. So it is the meniscus. Now what happened here? The meniscus is extruded. Okay, the medial cruciate ligament is pushed above, and also here you can see there are formation of, what is this called? Osteophytes. Everyone is silent here. I do not like this silent classes. Take this as a regular class. Do you remain silent always? No, na? So you just try to answer. Okay. So even if it is wrong, nothing there. It is only us, IPM people here. So here you can see meniscus extrusion and subluxation that can be there, and you will be able to see the tendons and ligaments abnormalities associated with the cartilage changes as well. Okay, and in case of reactionary or inflammatory changes, what we can observe, we can get a synovial hypertrophy, we can get a increased synovial fluid. This is a synovial hypertrophy. So you can see in the synovial hypertrophy, the changes are, it is also black, but unlike the cartilage, the margins are not sharp, and also there are small dot appearance within the appearance, and also in acute and subacute cases we will find this increased Doppler signal in synovial hypertrophy. And here in case of fluid, we will get a uniform black shadow and it will be compressible as well. So these are actually the signs of changes that can happen because of the inflammatory changes in case of osteoarthritis. Okay. Similarly, in osteoarthritis, there could be the suprapatellar bursa, which could be filled with fluid. So you can see previously in the picture, you have seen the patella, you have seen the prefemoral fat, suprapatellar fat pad, you have seen the prefemoral fat pad, and above here you have seen a very small suprapatellar pouch. But here you can see how the fluid is accumulated within the suprapatellar pouch, and here lies the quadriceps. So we can see the quadriceps at the top also. Okay, so this is the quadriceps tendon, and below we can see these are the important structures and important findings that we can see in case of suprapatellar bursitis. In the same way, you have to figure out the same structure in the short axis view as well. And while going into this space, usually we prefer a short axis approach, and with the needle we enter here to aspirate, or to, if required, we inject the visco, or we can go for the PRP injection by this way, so that we are not damaging the quad. So that if you go through the quads, you can go. In some cases, in early days of mine, I have also tried that, but it causes unnecessarily post-procedure pain, which is much more. It can be easily be avoided by going from the lateral side. So in most of the cases, we try to go from the lateral side and without hampering the quads. Similarly, this is a picture of the prepatellar bursitis. So you can see the fluid here at the prepatellar bursa. And this is the superficial and deep infrapatellar bursitis. This is the superficial infrapatellar bursitis. This is the deep infrapatellar bursitis. Okay. Then ACL, I am not going to the ACL because ACL is a comparatively advanced topic, and ACL is not exclusively for you because ACL will learn with time, and only ACL procedures can be done. For the evaluation of the ACL, you need the clinical evaluation, ultrasound, as well as the MRI, because ACL evaluation is incomplete without the MRI. Okay, and these are the few tests. Now coming to the medial knee. In the medial knee, I am not going to go much into detail because here the most important points, and mainly these areas that I have already told you, that here we have the medial meniscus, and above we have the two layers. One layer is the superficial compartment of the medial collateral ligament, and deep layer of the medial collateral ligament, and in between them you will get the genicular, medial genicular nerves and vessels. And here, if you want to do a genicular time radio frequency ablation, you have to reach here. Previously we used to do under the fluoroscopy, but nowadays we do mostly in case of with the help of the ultrasound. And by seeing these two arteries, first we look at the genicular artery, then we change the direction to the longitudinal direction. Then from front to back, we usually put the needle at this artery so that we are parallel to the nerve, and that gives excellent result. So, and here, preferably, we should use a cooled radio frequency. So this is the area. And the pes anserine is also very important. So just above this lies the three pes anserine tendons, 1, 2, and 3. They remains just above this portion of the collateral ligament. So there could be inflammation at the pes anserine tendon, and that could be painful as well. Okay. Similarly, we have the semimembranosus bursa as well. This is one of the picture of the medial meniscus tear, where we can see there is a torn meniscus at this point. There could be parameniscal cysts, where multiple cysts can be formed around the meniscus because of the degeneration. Plica syndrome, I am not going into much detail of the Plica syndrome. Let's go for the lateral knee. So lateral knee, we have, I know it's a little bit fast, so sometimes it is a little bit difficult for you to understand. But in the lateral knee, one of the important structure we have to look for is this iliotibial band. So what happens? It starts from the tibia and it attaches with the gyrus tubercle of the tibia and which goes above. And when it is going just by the side of the femur, at this point there is the friction and that can cause pain, and this can be evaluated by the Obert's test, and here you will be getting the ITB friction syndrome. It will look like this, and in the Obert's test it will give positive result. Okay, and we have to check for the lateral collateral ligament as well. Remember, lateral collateral ligament is less affected compared to the medial collateral ligament, as most of the injuries are the varus injuries valgus injuries rather than the varus injuries. And we have to check for the LCL attachments as well, and LCL in the short axis as well. And similar to the medial meniscus, we have to evaluate the lateral meniscus as well. Okay, and here also similar findings like the lateral meniscus cyst, lateral meniscus tear, they are possible to see. Okay. Next is the evaluation of the biceps femoris, and in the posterior knee there are a number of structures, but I have told the most important part is the posterior medial knee, and here you have to look for what is this bursa. So in between the medial head of the gastrocnemius and the semimembranosus, usually when you look for the posterior medial side of the knee and you look between the semimembranosus and gastrocnemius, usually at this point you get a comma shaped structure. Okay, and this comma shaped structure is usually the area in which the fluid accumulates, and just the by side we will get the gracilis, and there is a big triangular muscle. And remember, in upper extremity, in upper area, you said that always say that it is the sternocleidomastoid that is triangular. In the lower part, it is the sartorius which is triangular everywhere. So here you can see the sartorius and gracilis, and here we get the tendon of the semimembranosus. Okay, semitendinosus will come from above and they will come here as well. Okay, and you have to check for the fluid accumulation at this point at the medial head of the gastrocnemius. Okay, and you have to check the semimembranosus in long axis as well. Okay, I am not going into further detail of this presentation because it's a big presentation. Rather, let us see a few more cases that will be a little bit more inspiring to you to do the procedures. So this is one case that we can see, a case of knee effusion. So if we look at, so we are scanning the patient and here we get fluid. Okay. Now for this patient, I am telling the history. It's not a very old patient. Here the patient is having an inflammatory arthritis and associated knee fusion. Okay, that is why if you think it is because of the osteoarthritis, it's not, because there are structural changes are much less, but fluid is much more. But the quadriceps tendon integrity is there. Both the prefemoral and the suprapatellar fat pads you can see normally. So this you have already checked for, and this is the short axis view. So in those cases, definitely we have to go for the DMARD therapies as required for the disease, as well as we need to give the relief to the knee, for which at early stages we can go for the intra-articular injection of the Kenacort hexa or triamcinolone hexaconazole. Okay, that we commonly use, though nowadays it is a little bit out of market. In that case, we have to use the triamcinolone only. And here the patient is also having a deep infrapatellar bursitis. See, previously you have seen the picture of the deep infrapatellar bursa, but there was no fluid. But you see, now it is fluid filled. It is in the short axis view. Okay, so that you can see the fluid here also, and definitely in the long axis also, it will show the fluid. Okay, here it remains. Okay, and here lies the Hoffa's pad. Okay. Next, go for the, this is one of the cases I have taken just few days back. So it is a case of Baker cyst. So this is how a classic Baker cyst. I'm not telling this is a very painful Baker cyst because it was not a very painful Baker cyst. When it starts like this, but when it becomes painful, it is furthermore accumulated with the fluid. Okay, but in early stages, the typical comma shape of the Baker cyst that you can see here. So if you want to find a Baker cyst, previously you have seen a gastrocnemius semimembranosus, gastrocnemius bursa without a fluid, but here you can see a semimembranosus gastrocnemius bursa with the fluid. So this is actually the Baker cyst. Then it is a procedure. It is the knee aspiration being done. Okay, so see nowadays how we do? We do a totally different approach. So first we are giving the local anesthetic, and remember, try to be almost right angle your needle and the probe so that you can see the needle best. Okay. If you come from an angle, you won't be able to see the needle that good. And once you have put it, then you will put the needle. Okay. Now, if there is too much fluid, in that case, you don't have to give anything. Just by normal needle, you can get, it is not much deep. So you can go inside, you can aspirate, and also you can inject. Okay. So after the aspiration, if you want to inject steroid or if you want to inject the PRP, based on that, you can actually inject within. So first aspirate, that is very important, and then we'll be going for the injection. Okay. So that was a few important things. Any special request, because I have too many things on the knee, but in the short class I cannot cover everything. So I tried to figure out what could be the most important for you, and if any additional thing if you want from me to know, you can just say me.
Uh, Sir, good evening, sir.
Good
Uh,
evening.
Sir, if possible, can you show us the genicular nerves RFA ablation in ultrasound, sir?
Genicular nerve RFA.
Yes, sir.
Fine. I am trying to find if I have it. Yes, I will search genicular.
Actually, it is very difficult to cover everything.
Yes, it is a
And
very
so
short
that's why
class.
Dr. Debjyoti has tried his best to
The time
focus
is
more
very
on
short.
basic.
Okay, if I found the video, na, it is a too large presentation. I have to.
Large.
In fact, I have three more presentation. One on the anterior, one on the posterior, one on the lateral, like that. So I have to search from there. So it will take a little time. If I found, I will actually do one thing. I will share it to you. Okay, in the group. That will be fine.
Okay, sir. Okay, sir.
Any other thing?
More questions?
Hmm.
So we can conclude here, sir.
Yes,
Actually,
I
it is
can.
very difficult to cover everything. But you have covered nearly 80%.
Yes, I tried maximum, but
Yeah,
it is
all basic
difficult.
has been wonderfully covered. Uh, for advanced, you need one more class.
Yes. Okay, so let's say bye bye
Okay,
for
okay,
today.
sir. Thank you everyone to
There
join
are
our
no
meeting.
questions.
And at the last, I wish to introduce our moderator.
Right, there is no need, no need. It's okay, Anshul.
Okay, okay, okay,
I
ma'am.
didn't send the slide also. It is absolutely okay.
Okay, okay,
Okay,
ma'am.
let me
Okay.
introduce Madam Sunita
Oh
ma'am,
no,
our ex-president. Okay,
there
so
is
is that
no
one of
need.
the senior most pain physicians. That's enough, I think.
Thank you, ma'am. Thank
Okay.
you.
Only one line I would like to say to the juniors, like this was knee is very complex, and you need to repeatedly go on attending classes as well as do ultrasound because it is not so easy as it looks. So basically, just focus on what sir has said and try to do the basic first. The basic has to be clear before you go for advanced things. This is only the message which I wanted to give to IIPM fellows. And all the best to all of you. Keep reading, keep doing, and keep growing. Thank you.
Thank you, ma'am. Thank you.
Thank you so
Thank you,
much.
sir. Thank you, Debjyoti, sir.
Welcome.
Thank you.
Chaliए, good night.
Good night.
Good night.
Good night. Good night.